Good afternoon. My name is Betty Kasioka, Kiambu County, and this challenge goes to all of us, not just Dr. Awinja. As nurses, we do not need to beg for leadership positions. Can the nursing bodies, ECSACONM, NNK, Canaan, and everyone else that's involved in nursing leadership sit down and put down a policy document on nursing leadership from the top to the least most? And can these positions be filled competitively? Not because I come from your tribe, not because I'm your gender, but competitively.
Thank you so much. My name is Catherine Chacha. This goes to all our nursing leaders. There's this issue of sexual exploitation, abuse, and harassment at the workplace. And the most affected people, I believe, are nurses. What is leadership thinking about it? Will there be a policy? And how do we strengthen nurses in terms of reporting when it happens at the workplace? Thank you.
My main concerns is on medical legal errors for the nurses. Do we have a nursing framework that protects the nurses in the cases of medical errors? Because we find that when a nurse is found in such a state, they are left on their own and they do not know how to represent themselves in court.
Thank you so much, nurse leaders. Betty, asante sana. It is true what you are talking about on a policy for nurse leaders, but what we have in place now is the scheme of service, and that will address our career pathway. So what we need to do so much, although we have done 90% of review of that scheme of service, is we have really tried to make nurses be where they are supposed to belong. What you don't know, we have put 2 career pathways so that even if you're in clinical area, you are moving equally to the one in administrative area. We are able to input the specialized who are not there. We have argued our way up and we are reaching at the secretary director. And I think you are talking so much of the career pathway, Betty, if I'm not wrong. And this is just part of what we have included, and it is shared far and wide. And we had just problems to conclude it because of the HR. Now we have new HR and we are revisiting the thing so that we finish. Na mtaona kabla ikuwe signed off. But all of you are represented in one way or another in the development of this scheme of service. You can address Betty. I hope so. And then Catherine talked about sexual exploitation. This is real. We left it for reproductive health to do something, but there was law, just the way the norms and standards was low, and I took upon it for nurses only. And I'm really bringing it up. Because since 2014, nurses have been asking, Sasa, Atuna here, how are we going to help ourselves in the county? What proof do we have in the county so that we can move ahead? So we are doing the norms and standards for nurses. We are glad we keep on getting people to support us. And equally, this sexual exploitation for nurses, we're going to take upon it again and do something right up on it. Although they will say we shall be biased again, we just have to sit down with a very good justification again, the way we justified about our policy. Then the medical legal error who protect us, sijui kama Collins na Nyongesa na Tekla wako hapa. I'm not sure whether they are here or listening to this. They are the voice of nurses and midwives, and they really need to do so much. However, we have the police who has just left. Police wa nurses na midwife ni Edna, ndio police wetu. She's police, but sometimes when it comes, I also am a board member. We try to see how best can we try to protect this nurse, other to demonstrate that we have done something so that she's not subjected to very harsh punishment. So we try also our level best because we belong there, all of us. I think that's what I can say about medical legal. I don't know whether I've left any other. There were 3 questions. Kama address, please, utasema. Umia can add.
Thank you. I want just to add to where the DNS has left. If I understood what Betty asked, it was not so much about the career pathway, but the competitiveness to certain positions in the nursing structure, isn't it? We have those positions at the county, at the national level, that perhaps require some kind of competitiveness. For example, where the DNS sits. Tomorrow, if she retires, who should sit there? The county chief nursing officer. When the position falls vacant, do we have a kind of an organized system where everybody has an advantage, right? In terms of education now, nearly everybody in this room, you have the prerequisite paper, if that was to be applied. But I want just to say, Betty, if you listen to the presentation by Professor Koth, which I did on his behalf, we are in a very competitive world. Competitive world in the sense that, and I want to bring the context of the Kenya scenario as it is today. You know, every government of the day, they have what you call an alignment, isn't it? People that will be able to support their agenda. So there are levels in appointment that have political, they are politically manipulated. Are we together? And from where I sit now in the ministry, I understand this very well. In fact, I say I used to be a civil servant. Now I'm in the government because I'm able to, you know, to smell food when it is being cooked. You understand what I mean? As a ministry, even as we speak now, we have not gotten the structure right. Why? Because of political interests. That's one. The other challenge that we have is, you know, the Health Act of 2017. Health Act of 2017 has become an elephant, even to the CS herself. The other day it was in the media that all the 53 positions which were appointed, the Labour Court, did anybody read that? Did what? So they rejected. Why? Because the Health Act of 2017, it is very prescriptive. And law is law. You can only change law if you amend it. So in the counties, do you have policies that guide how people should be appointed? You don't even have structures, isn't it? So we need to be politically connected to influence. Influence your MCS. When they go to do legislation, do they raise this as concerns? In Parliament, we've been asked, why is everybody in Afia House, from the Director General acting to the head of a division? Why are they all acting? What is the problem? So we need to engage, we need to influence, we need to be politically aligned.
So thank you very much. I'm also learning, and I think the issues of sexual exploitation at workplace, as much as the nurses might be affected, but I think it cuts across all cadres. And this has stemmed not only from the workplace, but most of the time is from the institutions that we've come from. Maybe it's the university, the college. So unless we address these issues from the institutions that we have worked and empower the people that have been victimized, we will not be able to address it. But I think as institutions, we need to put up, we already have the acts, it's just to put them now into practice. Put up probably a legal office within our institutions where people can comfortably go and put their complaints. If we don't do that, it will always be something that is undercover. Thank you.
I have the first question, which asks about, despite the maternal death in the community, how did you improve? Which was not mentioned anywhere. So in our project, we involved the community by doing community dialogues. And earlier on, we had initiated community verbal autopsies, which were not being done. So during the verbal autopsy, we could get most of the challenges which we are facing at the community level. So we were doing this together with the community strategy. So we had really improved in terms of also referrals and handling cases at the community. So we are reporting community deaths, and we are doing verbal autopsies. And the second question was, in Mombasa County, staffing is a major concern, which is retarding quality service delivery, more so in our maternity unit. Most level 3 hospitals operate with as low as 1 nurse per shift. What can be done to lift this big monster? So I think this question, at my capacity, I might not be able to answer it because it's mostly touches on staffing. That is part of the county team. But in our level as RH coordinators in the sub-county, we have really tried, even coming up with MPDSR champions group in the WhatsApp, whereby the facility which are short-staffed, they can shout for help and they can get help immediately. In that group, we have the county team, the directors, the chiefs, the facility in charges, the gynecologists. So in case of any emergencies, we really try to make sure we evacuate the patients as immediately as possible to the referring facilities. And then the other question was on, I hope I've answered the question well. Then the other question was on the documentation of the referral form remained the same before and after your intervention. So what I've noticed is, okay, there were 3 bar graphs there. So the one, I think the person who asked the question, she looked at the cumulative, which was the same at the beginning of the intervention. So the documentation changed after the intervention. It was only 2 facilities who had not documented, no proper documentation of the tool. So the second question was, how can documentation of care before and after referral be improved based on your experience? So it was improved because we customized the referral form for the maternity. In the general referral form, which is available in the national guideline, it does not include some of the maternity indicators in the form. So we customized it and included the gestation, the parity, the attendance of the clinic, and also during the referral, what was the fundal height and the other maternity parameters, so that while handing over, this nurse receiving can be able to get a clear picture of what is being referred. Thank you.
These are very good that only 10 to 20% of patients, mother, go through CS in your hospital. In the same period, were there any negative outcome that could have happened due to missed opportunity for C-section? I would say yes, but our study was not concentrating on those who were not, those who did not give birth through cesarean section. So during that study period, we had a total of 10,226 delivery. That was 1 year. And out of that, 1,920 underwent a cesarean section, which gives like 19% rate. And yes, there are other clients who missed cesarean section and they needed it, but we did not look at it. The next question was about labor care guide. What does it contain? Is it different from pathograph? Labor care guide, if you Google from WHO website or even Google Scholar, you'll find the labor care guide, which is a guide to labor. The World Health Organization recommendation is we move from pathograph and we start implementing labor care guide. At our hospital, we are almost starting using. We are still sensitizing the midwives and the obstetrician on labor care guide. We haven't started using it. We are still using pathograph. It's more detailed compared to pathograph. They have separated the fetal side and the maternal side, the parameters, but it's more detailed than pathograph. If you look at labor care guide, you can easily tell every detail about the client you are managing. So I would request the owner of this question that you just Google labor care guide. It will give you like a PDF, almost 100 pages. Thank you.
The first question is about having the bundle approach integrated in the in-service training. I will request my CEO to talk about it briefly because she's already doing something about that. The other question is, how effective is the anti-shock garment? Yes, anti-shock garment is effective in about 2 to 3 women, among 5 women, 2 to 3 will be saved because most of our women come to maternity or to deliver when their HBs are very low. So the action behind the NASG is that it gives, it applies pressure on the lower extremities so that we can have a backflow. Remember when we have PPH, all organs are donating to the uterus. And so we want to have a backflow into the heart and the brain. So most of these women, 2 to 3 of them will be saved out of 5. So NASG is very effective. So I'll request Dr. Monica to talk something about in-service.
Thank you. Due to time, I'll take a very short time and just remind us all, nurses and midwives, that we need evidence. We need this evidence to engage, especially if we are to include this in the training institutions. This is work in progress. We are already working with the DRH. I hope they are in the room. The big 5 guidelines, and we are seeing that we need to go beyond pre-service to now go and involve the institutions. There are quite a number of institutions that have approached us. We are working with them. MTCs, are they in the room? Anybody from MTC? Yeah, I think we need to bring on board all the training institutions and start discussing the innovations that make a difference so that it is in the in-service training guidelines. At the county level, the other thing I want to encourage is that we bring more institutions at the county level so that they are in this space and they understand what has changed. I just want to assure you that in the next meeting, we will be sharing what we are doing with the training institutions. Aga Khan, we are on board in the discussion. Thank you.
The first question is, what are the possible explanations for the multiparas having low uptake of IPTP? One is that the late ANC start, and especially for multiparas, some of them feel that they are experts now, and therefore they start going to the clinic late, and some even still believe that once you have the antenatal clinic book, then when you go for delivery in any facility, you will register for Linda Mama and you will be assisted. So they wait until late, and therefore they miss the preventive treatment for malaria. And maybe on that part, we also need to carry more research to find out the outcome now. What is the outcome of the delivery in terms of maybe birth weight, HB at the start of the clinic and at delivery, and so that we see more effect on the uptake of SP. Then if SP is the preventive measure for malaria, what is given to those who are allergic or have an allergy to SP? Actually, the other group that is not given SP is those who are on daily cotrimoxazole, and also those who are allergic
they are not given SP. However, SP is not a standalone malaria preventive treatment in pregnancy. We have other interventions like the use of LLIN, use of the insecticide-treated bed nets, and also like in the lake endemic regions, we do spraying, indoor residual spraying. So we are encouraging them to embrace those other interventions. Thank you.
Somebody asked for no-scalpel vasectomy, why target 25 to 40 years when men are sexually active beyond 45 years? Hey, okay. So we targeted this age because it's easy to change the young. It's easy, they get the information when they are young. So if we were to target, I know men are sexually active beyond even 70. But of what Nini would it would not be of so much help because at that age, most of the time, their families are done. But if you do it with these young men, 25 to 40 years, then change will start. At that level. It will be easy because it's like they'll be growing with that information. It's easy for them to change their mind when they are young. Thank you.